Hello, my name is Melissa Holland, and I am from Sacramento State University in Sacramento, California. And today I'm going to be presenting on risk assessment and crisis intervention in a time of telehealth when working with youth. So first, just a few statistics on youth mental health. Depression, anxiety, and suicide rates are on the rise for our young people. Recent survey research found that almost 20% of respondents were found to have seriously considered suicide, with almost half of those actually having attempted suicide. With regard to specific populations, females are at much higher risk than males of having suicide ideation or suicide attempts. And LGBTQ youth also have been found to be at significantly higher risk for depression and suicidality. A recent study conducted by the Center for Disease Control in 2020 found that suicide is the second leading cause of death for youth ages 10 to 19. With regard to COVID and mental health, the increased social isolation from the pandemic has exacerbated many mental health concerns for our youth. In addition, family conflict, economic and health concerns, as well as disruption to typical routines and support systems have all contributed to worsening mental health for our youth during this time. In survey research, it was found that about 40% of participants reported having one or more adverse or behavioral health symptoms or trauma or stress-related disorders that were linked directly to the quarantine or to COVID-19. The effects of COVID-19 and the pandemic have also been shown to disproportionately impact minoritized youth. And so in comparison to 2018, suicidal ideation cases have doubled. Since the pandemic, more than a quarter of high school students have reported worsening emotional and also cognitive health. And over 20% of parents with younger children reported similar worsening conditions for their children. Existing literature also shows a strong relationship between social isolation and suicidality in youth. And so in addition to loneliness and isolation with regard to the pandemic, also the poor mental health of parents may be a contributing factor in negative mental health outcomes for their children. Looking at the long-term impact of loneliness, there was a recent research meta-analysis looking at 83 studies on social isolation and loneliness. And what was found is that being isolated increased the risk of depression and anxiety, both at the time which loneliness is measured and also up to 9 years later after that period of time. And what was found that it's the duration of the loneliness that's more strongly correlated with mental health symptoms than even the intensity of the loneliness. So when we think about that and how the quarantine in both the United States and also in many other countries has led to a lot of social isolation and also loneliness for our youth, it's really important that then we as clinicians offer preventative support and early intervention services where possible, and be prepared also for an increase in mental health concerns with our young people. A study specifically looking at quarantine effects found that parents of children who completed a survey about the effects of the quarantine on their children, 85% of parents reported some change in their child's emotions or behaviors during the quarantine. Most of the symptoms included difficulty concentrating, being bored or irritable, feeling restless, nervous, or lonely, and also just having general worry. And in addition, about 75% of parents reported also feeling stressed about the quarantine situation. And we know that parental stress is associated with increased risks of mental health concerns for their children. With regard to mental health service obstacles in general, access to mental health is inhibited by financial insecurity. Sometimes families simply can't pay for the services. There may be an absence of insurance coverage for some families, or if those families do have coverage or services, a lack of transportation perhaps to get to and from appointments, or perhaps parents work during the times when the appointments are happening, and so they aren't able to transport their children to the appointment. And then also difficulty navigating the stigma associated with mental health. And as a result, most children will not receive treatment. It's found that only 1 in 5 youth with a mental health disorder will actually receive any form of treatment. Therefore, the provision of mental health services via telehealth has been identified as one possible solution to those problems that I just shared with you on the last slide in order to improve access to care for children. What is telehealth? Telehealth is simply services that are provided through a range of telecommunication technology, such as Zoom, mobile devices, texting, real-time online video, conferencing, etc. And telehealth affords a number of advantages. There's immediate access to care, even if there's a lack of transportation or if a family lives in a more remote or rural area. There's an increased ability to incorporate caregivers and other professionals in the service, as you can also Zoom with them or do telehealth with them. And there's also an improved ability to provide comprehensive services, such as an increased access to more specialized healthcare. When looking at the research backing, there has been some randomized controlled trials comparing both in-person services to telehealth therapy. And what was found is that various modalities such as cognitive behavior therapy for depression, treatments for obsessive compulsive disorder, and also behavioral treatment of tics have all been proved to be successful over a telehealth model. And also the effectiveness of telehealth and doing family intervention has also been documented. In studies looking at clinicians' perceptions of school-based telehealth, students actually appeared more comfortable communicating with their therapist through video conferencing. The use of technology and video conferencing is a very it's a very accepted means by youth. Most youth feel pretty comfortable using some form of technology, and youth often disclosed even more information than they typically would over a telehealth modality than during in-person sessions. Research on telehealth has also shown a high report of parent ratings of a perception of safety, of the quality of services provided, of the savings that families can have, increased trust in school personnel, and also offering the opportunity to increase family and school collaboration. According to the American Psychological Association, it's found that active suicidality is not considered a contraindication for the use of telehealth services across the age spectrum. Therefore, what that means is if a child is exhibiting some suicidal ideation or behaviors, telehealth does not have to be ruled out. Looking a bit, we'll be talking today briefly about both suicidality and also non-suicidal self-injury, or NSSI. Both those experiencing suicidality and those engaging in some form of self-harm or NSSI are generally driven by a desire to manage or eliminate overwhelmingly and seemingly intolerable stress or psychological pain. And the important distinction that needs to be made between NSSI and suicidality is intention. Those experiencing suicidal thoughts or engaging in suicidal behavior have a desire to end their lives, whereas those engaging in NSSI do not intend to die, but rather are trying to relieve emotional pain and therefore lower their psychological distress. Risk factors for engaging in NSSI include feeling isolated. So that's something that we really need to attend to during the pandemic. Having few effective mechanisms to cope with emotional stress, feeling worthless, or having a history of trauma, abuse, or chronic stress. And again, due to the increase of social isolation brought on by COVID-19, it's really important for mental health professionals to openly address both suicidality and NSSI with their students at the onset of treatment. Risk factors with regard to suicide are common for both males and females, including running away from home, perhaps engaging in some form of self-injury, having a sexual abuse history, experiencing depression or other mental health difficulties, and also feeling hopeless. And although females have higher rates of suicide attempts, males actually die at a rate approximately 5 times that of females due to the fact that they use more lethal means, for example, firearms in their attempts. Situational risk factors include being bullied, having a disciplinary action either at home or school, going through some form of relational breakup, or experiencing an academic failure. And COVID-19, with regard to situational risk factors, have created more social isolation, family conflict, and also a lack of typical routine and support networks. And all of that can create an increased risk for our youth for suicidal ideation or attempts. So with regard to evaluating risk, it's essential to evaluate the risk factors in relation to the current pandemic. For example, we need to look at their increased social isolation and increased feelings of anxiety and depression, and also to identify access to the lethal means that they may have integrated into their plan for how they would commit suicide. Because so many youth are in and out of the home more during this time. Many of them are still doing school over some form of technology and being at home during school hours. It's important to ascertain how safe the home environment is and what their access is to things like medications and weapons. It's also suggested that we frequently monitor suicidal symptoms, both during treatment and at the end of treatment, using screeners such as the Beck Depression Inventory for older teens or the Children's Depression Inventory. When conducting a risk assessment via telehealth, it's really important to first confirm the location of the client and also to discuss with the client what to do in the case of a technical malfunction. So for example, if this Zoom meeting just dropped, I could try to call on the phone instead. It would also be helpful to know the approximate area of where the parent is during your telehealth meeting. Is the parent at work? Are they in the home as well? And so that way, if there's an immediate concern, you can have access to the parent or guardian. While verbal consent from a legal primary caregiver is recommended, if it's a first-time meeting and a risk assessment is being conducted, which is considered more of a crisis intervention, verbal consent from the primary caregiver is not required. However, after that first session, similar to in-person counseling, informed written consent is required. And school districts must be sure to update their existing consent forms to reflect information related to telehealth, including the risks and benefits of telehealth, and also the ways to electronically deliver the consent forms. So once you have determined that the youth is physically safe where they are during your virtual session, and you also know the location of where they are, if the risk is considered very high, obviously the youth may need immediate professional help whether it's inpatient psychiatric care or going to the local emergency room. However, it really is best if the family, the parent or guardian can transport the youth themselves, because sometimes contacting emergency surgery or emergency services to go to the family's home may cause further harm to the mental well-being of a client, especially looking at our minoritized youth, and that can result in more of a traumatic experience. So if the child is deemed to be at risk, it's really best that the parent or guardian transport that child either to the local emergency room or to emergency inpatient psychiatric care services. Once it's been determined that the youth is not imminently at physical risk for harm, it's important that you collaborate with the child in developing a safety plan. So in contrast to safety contracting, which doesn't have any empirical evidence supporting its efficacy, and it's really focused on what not to do. For example, I will not commit suicide. Safety planning is collaborative in nature and focuses on what the youth is going to do. So elements of a safety plan that you can help construct with the child virtually include recognizing the warning signs of an impending crisis, working with the youth to recognize when they're starting to have thoughts of harm, for example. Create a list of coping strategies that the youth can use if they notice that they start to have some of these warning signs, such as self-soothing activities. Utilizing socializing strategies as a means of distraction and support. For example, make a list of important social contacts that the child can call if they're starting to have thoughts or feelings of hurting themselves or harming themselves. Contacting family members to help resolve the crisis. For example, knowing who to call and the times of day that each support person is available. And you can construct this form with the youth while you are on a telehealth session. And then also obviously reducing any access to lethal means. For example, if the youth said that they would overdose on their parents' medication, to make sure that that medication is safely stored and locked up. And with regard to interventions, though some individual interventions such as cognitive behavior therapy or dialectical behavior therapy and mindfulness are identified as current best practice for follow-up care with at-risk use, youth outcome research is somewhat mixed or scant in a telehealth modality. Overall, DBT, A, and what the A stands for is dialectical and behavior therapy with adolescents, does appear to be well supported for youth at risk for harm to self to date. Although it's important to note that DBT programs for youth have not been formally adapted to a telehealth setting. And family and caregiver involvement significantly improves the quality and outcome of intervention. And this can really be helpful over a telehealth model, as you may have more access to the various people in the child's home through a telehealth model than perhaps more of an office face-to-face meeting. So in conclusion, further research is needed in order to identify best practice intervention when it comes to working with youth on a telehealth model. However, telehealth does appear to be a viable alternative to in-person services. It removes many of the obstacles that are there present with current mental health care. And also suicidality is not contraindicated in a telehealth model, and we can help our youth in creating a support plan if they're starting to have thoughts of hurting themselves, and we're working with them over telehealth. Thank you so much. I appreciate it, and I hope you have a good conference.